Hi, and welcome to today's webinar. So you want to start a peer-run warm line, ideas, information, and inspiration.
Muted.
This webinar will last approximately 90 minutes, and this training teleconference will be recorded. The PowerPoint presentation and audio recording of the teleconference will be posted to the NEC website at the link below, which will be available online as well. At the end of the webinar, there will be a Q&A session. You're invited to ask questions at any time through the question function in your GoToWebinar control panel. You may also ask a question via the hand raise function if you wish to ask a question verbally. Questions will be taken in the order that they're received. Just wanted to run quickly through today's agenda. I'll be doing the housekeeping and speaker introductions. And then we will have Oryx Cohen give a presentation on what is a peer-run warm line. Then we will have Angel Moore. Unfortunately, Trinity could not be with us today, who will talk about the experience of running the David Romprey Warmline, followed by Julio Briones talking about warmline technology. And after that, we will, as I said, have time for Q&A before we conclude. So now I'm going to introduce the speakers. We are very fortunate to have with us today speakers with extensive firsthand knowledge of warm lines who are here to share their hard-won experience. And I'll go ahead and introduce them all now, and then they will each speak one after the other. Our first speaker is Oryx Cohen. He's the director of the National Empowerment Center's Technical Assistance Center. He assists states to develop their consumer survivor voice and work towards transforming mental health systems to become peer-driven and recovery-oriented. Oryx is also the co-founder of the Freedom Center, the Pioneer Valley's only independent peer-run support activist organization. Angel Moore works for Community Counseling Solutions as manager of the David Romprey Oregon Warmline and is a certified national IPS trainer. Angel says recovery became a new way of life, living without the use of drugs, and now a life of mental wellness and stability. For the past 16 years, Angel has shared her experience, strength, and hope without shame or guilt so that it may inspire someone else to share theirs and help others. And Julio Briones works with Mental Health America of Montana. He heads up social media for M.P.A, which includes podcasting, Facebook, Twitter, YouTube, and video-based peer support groups. Julio also runs the M.P.A website and puts out their weekly e-blast mental health news updates. And without further ado,
Unmuted.
Please go ahead. Thank you.
Hi everybody, this is Oryx Cohen. It's great to be on this webinar, and thanks for the introduction, Leah. As Leah said, I'm the Technical Assistance Center Director, and part of our work involves the concentration area of quote-unquote crisis services. And we actually include a work on peer-run warm lines underneath crisis services, which is a bit controversial in our movement, but we really feel strongly that it belongs there, and I'm going to talk a little bit more about that, and welcome to have a discussion about it afterwards as well. So what are the basics? What is a peer-run warm line? It's a phone number you can call to talk to someone who has been through it. And later on also with Julio's presentation, it may turn out to be more than a phone number in using the technology and doing maybe through video, through Skype. We'll talk about that as a possibility. It's staffed entirely by people with lived experience with mental health issues, trauma, or extreme states. They can be local, regional, or national. It's really a decision that's up to the people starting the Warmline, and redefines crisis. And we're going to talk a little bit more about that. If we could get to the next slide. Okay, so these are some possible Warmline models. And as in the last slide, I mentioned that you can do these locally, regionally, or nationally. And that's the first decision really to make is, do you want your Warmline to be local to the area, just the local area code? Do you want it to be regional or statewide, or do you want your Warmline to be national? And this is an important decision, because if you do decide to make your Warmline open to outside callers, outside the state or outside the area, it's really important that the operators on the Warmline have some training in how to refer people to resources in other areas outside of their area. So it's an important consideration. And these are some of the possible models. You can have a virtual drop-in centers, which Julio leads in Montana, and is going to talk a little bit more about, where they really make excellent use of technology and are even thinking about things like Skype. You can have standalone versus cohabitation, and what that means is you can have a Warmline that's just a Warmline, and that's all it is. It could be something just very simple as one person with a cell phone, or you can have a model that's cohabitation, which means that it's part of an existing program. A lot of the peer-run respites, for example, are including Warmlines in their design, and they have, in that way, they have some infrastructure already built up. They have a house, they have an office, they have a phone, that kind of thing, built into the existing place, and it's easier in some ways to start a Warmline that way. You can have volunteers versus paid Warmline operators, and obviously with volunteers, it costs less for you to operate the Warmline, but it may be difficult to actually, and sometimes it may be difficult to actually pay people to find money in the budget. The good thing about paying people is that it tends to lead to more commitment on behalf of the Warmline operators, and also just honors their work. A lot of times in our movement, we're underpaid for things, and we do a lot of things volunteer. So there's definitely pros and cons to using volunteers and using paid operators. And I think some of the speakers may get more into that as we go along. And the last thing on here is central location versus call forwarding. And that means you can actually have a physical location where people go in and answer calls, or what's more and more common is just using cell phones and having a central number that is forwarded to people's cell phones. And of course, there's pros and cons to each of these. With the central location, you have better access to supervision and to communication with other workers and more support, but you don't have the flexibility that you have where you can answer the phone pretty much anywhere where you can get reception. So can we get the next slide, please? All right, and just to close my section, some important considerations when thinking about starting a Warmline are to collaborate with other groups and organizations. Definitely, let all the mental health organizations know what you're thinking, and start talking with different groups as you think of starting a Warmline. The more support that you can get, the better, especially to get funding. You want to educate yourself on all kinds of resources that are available in your area, or even nationally if you want to have a national Warmline. so that you're able to refer people who call to good resources in your area. You want to think about what hours you want to operate and make sure that maybe they complement other warm lines in your area. You want to think about technology, which Julio is going to go into depth on. And you really want to focus on training your operators and supporting your operators as best they can. It can be a stressful job to answer some of these calls, and even doing peer support is stressful. So would like to emphasize, again, as I mentioned in the beginning, that warmline operators can handle almost every quote-unquote crisis situation, and so warmline. It's my opinion that warmline operators should get really good training on how to handle crisis situations, because even situations where people are feeling suicidal, etc., I believe can be handled by peers, and even better than clinical organizations can do that, just because of our lived experience. And there are trainings available. We'd be happy at the NEC to help people develop such trainings. We just really hate to see people calling the police and calling providers and emergency services too quickly in a lot of instances. So that's about it for me. Be on the lookout for a Warmline guide that we are creating with National Warmline Leaders Help. That should be published this year. Thanks, Leah, for the next slide. In collaboration with the Self-Help Clearinghouse, actually, and that's their website there, the mhselfhelp.org. The David Romprey Oregon Warmline is one of the contributors to the guide, as well as the M.P.A, the Montana Health Association Warmline, is also a contributor to this guide. And so just be looking forward to that. And you can also just check our website, which is there, thepower2u.org/peer on warmlines, for any updates. And we will also put the archive of this webinar up there as well. So thank you for your time, and I hope you enjoy the other presenters.
Muted.
Thank you so much, Oryx. That was a great overview. And now I'm going to turn it over to Angel Moore.
Thanks so much. Hi, everyone. My name is Angel Moore. And David Romprey Oregon Warmline. And I work for Community Counseling Solutions here in Oregon, and we've been doing this for about 4 years. Next slide, please. Just to give you an overview, in the beginning, we started in November of 2007. We hired a professional consultant and trained warmline operators to provide warmline services. We reviewed the differences between a warmline call and a crisis call, and we discussed under what circumstances was it appropriate for warmline peers to contact the crisis professional. When we talk about crisis, what does that really mean? Everybody has their own worldviews and own understanding of what crisis means, and so for our insurance policies, we had to have some sort of protocol in place. So keep that in the back of your mind when you're thinking in terms of quote-unquote crisis professionals. You have to have some sort of backup plan for insurance purposes. Okay, next slide. So we originally got $25,000 from the state of Oregon for a block grant, and just to try it out, 5 hours a week. And this combined with funding from Community Counseling Solutions, we began that pilot. Okay, next. So that first 5 hours a week was the only shift. We had 2 operators operating from one location, which happened to be the least populated county in Oregon. It's about 1 person to every 5 square miles. So that you can do a Warmline just about anywhere, or I believe anywhere. Then we went and we marketed the Warmline to all the community mental health providers in Oregon to generate some interest to add hours for a small annual buy-in. At this time, we didn't know what the costs of the Warmline were going to be. So Community Counseling Solutions put up enough money to fund it for a year for my position at that time, and just see what we can do with it, how we can get people to collaborate and come on board. And so this $5,000 really was just a way to say, hey, look, if you put $5,000 into the Warmline, we will come to your location, which your county, your area, what have you. We will train your peers, and if you provide us with an office space and a phone, we will train the people in your area locally. So community mental health providers really liked that idea because we were contracting with them, so we held all the liability and all of that. And they really liked that as far as they didn't have to do it. They didn't have to put more money into it. They didn't have to manage it, any of that. And so we got about 7 more counties to buy in at that amount. So it was also an opportunity to start a peer-delivered service within those communities that didn't have them already. And so even though it was under our organization, it was in their community, so their money stayed local, and it provided an opportunity to begin a foundation for community peer-delivered services within smaller and larger communities. Okay, so next slide. So we had 7 community mental health providers bought in for that 1 year. So then we went from 5 hours of operation to 35 hours of operation in a short amount of time, in just a few months. And after one year, then we were able to see the data collection of the usage, and it will. So after that year, we were able to really see what the true costs of the Warmline were. And so anyone who wanted to buy in after that had to buy in at the actual cost that it actually took to run the Warmline. Next one, please. So then it went from, we were able to take an average on what it would cost for 5 hours of operation, and that included an operator, that included a team leader in that location alongside the operator. It included some administrative costs and the costs for the phone and you know, payroll and all that other good stuff. And so then we were able to see that it was really about $15,900 per year for 5-hour shifts. So this is, I forgot to update this here. We actually operate 78 hours a week currently, and but we operate total weekly of 138 hours a week, because just 2 months ago we had a county sponsor an additional 78 hours per week. So now we have multiple operators on the line at one time. Sometimes we have 1, sometimes we have up to 4 operators at any given time. And then at year 3, we were awarded $190,000 a year by the state of Oregon to sustain the program for an additional 2 years. And with that funding, they asked us to do a feasibility study, and we're in the middle of doing the research now so that we can approach the insurance companies and the community care organizations that we have here in Oregon to provide ongoing funding after they see the cost savings that we we provide them. And then just this last January, we were given an additional $250,000 a year from Clackamas County to increase the hours by 78 additional hours. And they operate their location 7 days a week, which is pretty exciting. So really our annual budget now is just under $500,000, and we began with a pilot dollar amount of $24,000 4 years ago. Next slide, please. So all of our Warmline operators are trained in intentional peer support by Sherry Mead. It's her curriculum. I was trained by Sherry Mead and Chris Hansen to be a facilitator, and so I train all of the Warmline operators here in Oregon. As they come and get hired, they have to have the IPS training. And then for Oregon, we had to add a 6th module to Sherry Mead's training with her permission. We added HIPAA, chart notes, those sorts of things. We don't chart on the Warmline, but that was a requirement for it to be approved by the state of Oregon to be a recognized peer-delivered service curriculum within Oregon. So we train everyone 40 hours and then ongoing co-supervision and ongoing mentoring and training in each team. Next slide, please. And then ongoing support and training. Operators are invited to attend IPS again and again as they need to. I'm sorry, my computer just went dead. Or as they feel they want to. If they want ongoing practice, we practice in each team at each location. We have team leaders, and we always continue the practice of intentional peer support. It's really been a huge foundation for the Warmline, and I believe that that's why we have so many calls coming from around the country as well as outside of the country, is because we have a bit of a different approach, and Sherry Mead's model is amazing. So then the team leaders have ongoing support groups using the IPS manual as a guide for further practice. The team leaders are not facilitating this. What they are is they're leading the discussion to where each operator practices a chapter within the manual that was given to them. And so it's a personal development as well as a professional development. And then our coordinator, Trinity Guayante, meets with teams ongoing support and practice and team building activities. She also meets with each individual to learn with the operator and support them through their goals of working for CCS. For instance, skill building, computers, and things like that. Many people who come onto our Warmline have never had jobs, or if they have had jobs, they have had different types of jobs, and maybe they don't know how to turn on a Warmline. And then we have, on the other end of the spectrum, people who come in with master's degrees that want to work the Warmline and have a lot of different abilities. And so having a good mix of learning opportunities for everyone, it's pretty amazing. We've had people who have never turned on computers come to the Warmline, and then after a couple of years decide that they have built up their skill level to where they now want to go and work in other areas of peer support or even go to college. So it's also a kind of a supportive employment opportunity for someone as well. But that's not the main focus. It just kind of happens. Next slide, please. Some of the day-to-day operations, we have 13 locations in Oregon that have Warmline operators from each site. Each location has a team leader support, and all the team sizes vary. We have as little as 2 people per location, all the way up to, I believe, one county has 12 individuals, 10 individuals, something like that. Each location is designated 5 hours per week of operation. These hours are shared in rotation for each operator. Now that's with the exception of Clackamas County, and they operate 78 hours per week. That's 7 days a week. And that's within their new crisis center called the Centerstone. And so we provide an ongoing body as well as warmline operation out of that site. Next slide, please. This is just an example of kind of how it's funded and how it's set up. So the agencies such as like Douglas County, they might have within Douglas County, they might have multiple sites. Currently they do not. They have one site and potentially one other site that we would like to see open. So the agency is the sponsor. They're the financial sponsor, and then the county within that agency's area the sponsoring agency might not be a county agency. It might be, say, a mental health organization. So it might be a region that has multiple counties that has different sites listed. So it's kind of what we're explaining here. And then within there, you might have, then you have the list of employees and who the team leaders are, who the individuals are that operate the line, and what location they're in, etc. Next slide, please. This is another example of that set up with two different sites. So Clackamas Community Health actually has two separate sites that they operate from. The Clackamas Happy Valley is operating the 68 hours per week, and then the Clackamas Wilsonville operates 10 hours per week. And so the Wilsonville location is actually set up in an area where there isn't a lot of bus transportation within the county, and so people who reside in that area don't have to drive or find transportation or get all the way to the Happy Valley location. So they participate. They can walk out their front door and go up some stairs, and they can work the warm line. Or they, if they choose to, they can drive to Clackamas Happy Valley if they have transportation. Next slide, please. We have the 800 number that allows anyone to call the warm line. We didn't originally plan on advertising nationally, and financially it really is somewhat of a burden to us because we do get so many out of the state and out of the national, out of the country calls, and so we are exploring opportunities to have others collaborate with us. Our phone system is pretty high tech, and we can have people on the same 1-800 number, but just pushing a different number that they want to, say they want to connect to Pennsylvania or Alabama or Ohio, that they just push a number and be able to do that. We're really thinking about that because of financially, we're using our Oregon money to support a lot of, about half of our calls come from out of state. So keep that in mind as you're putting, your warm lines together. If you wanted to find a way to collaborate, we're probably already supporting some of your callers or your residents of your state. So as an operator comes on shift, they log in to have phone calls forwarded to their location, and each operator collects information at the end of each call to collect specific data. It's optional for the caller to answer the questions. They don't have to, and they're not personally identifying. It's more geographics and then some. A series of questions are asked. I already said that. So next slide, please. So this is kind of what it looks like. So here are the locations that link into the 800 number. Just to give you a visual, I'm a very visual person, and sometimes I just can't see it. And so anyone from one of these little outer circles will call into the 800 number and enter in a passcode. And so then any number that comes into this 800 number will then be routed to whomever entered the passcode. And again, you can have more than one location on at one time. Next slide, please. So this is kind of how it looks. So if you imagine Grant County being the first person who logged on to the 800 number, then they're going to be what you call Find Me Number 1. So any calls coming in, the first call that comes in will go to Find Me Number 1. If Find Me Number 1, if Grant County is on the line when another call comes in, then it will go and it will forward on and bypass Find Me Number 1 and go straight to Find Me Number 2, and so on. So currently we have some days that we have 4 people or 4 locations around the state that are on at the exact same time or overlapping times. Next slide, please. Some of the data that we collect, we ask each operator to initial. This helps us identify who may need support when collecting the stats, and if there is a crisis referral, we know who to talk to learn more about the nature of that call. And that's not to say, oh, we want to know who this person is or what happened, or, you know, that might be part of it, but we also want to be there to support that operator. We've had people who have been extremely triggered and, not extremely, but who have been triggered and didn't process through that. And so they then later would say they didn't want to work the Warmline anymore, or they wanted to take a break, and we weren't able to identify that that was what was the problem, or that was what their challenge was. And so, and then also, if someone was referred to any alternative crisis line or something like that, we definitely would need that person to be available if someone needed to talk to them. We also track the date and the time in and the time out of each call. We do ask the caller their name. This doesn't have to be their real name, just a name to call them. And that's only so that we don't say, excuse me, or it's common courtesy, but we don't keep their names. We just use it for that moment. We do ask the gender of the caller and type of call. If they called, if they left a voicemail and they couldn't get through, did they hang up? Did we call them back, etc. Next call. Next slide. Yeah. We do ask we do put down the reason of the call. If someone just called just to talk, maybe they called just to thank the Warmline. Maybe they called initially because they were feeling suicidal, family matters, etc. We ask if people are a vet, what county and state they're calling from, and the insurance type. And we don't ask for identifying information on their insurance, but we want to know who we're reaching. And then also we have the Medicaid here, Oregon Health Plan, has something called P.E.O. data, which is Prevention, Education, and Outreach. That's a set of money that each county gets every 3 years, and if they don't use it, they lose it or have to pay it back. Well, this was also an incentive for us to, for others to buy into our Warmline. So if the sponsoring agency has given us money to operate the Warmline in their area, then any call that comes from their county, we will give them the P.E.O. data. So we will just say, yep, they called from your county and they're on the Oregon Health Plan, and here's how much you can get credit for. So so that was a real incentive for counties, community mental health providers, and so on to also contribute, because then they're also getting a financial kickback, if you will, or credit with the state, so that they can use up some of that money without having to pay it back. Next. We also asked how they heard about the Warmline. Was the call helpful? And if this was a huge one for us to get funding from the state and funding from future funding, we asked if they didn't have a Warmline, would they have accessed a more costly service, such as 911, hospital crisis lines, case managers, etc. This data is used to identify a cost difference and an analysis to show the savings around the state. That was huge for us when we went to the state of Oregon and said, look how much money we're saving in these areas, not only for the state but taxpayers, and keeping people out of these hospitals if they where they don't have to go to them. They can just call and just process through whatever they're going through, and that was huge. And then we track whether or not a caller was referred to 911 or crisis support. And then this last question is because I want to put together an ongoing program, which is an outreach program. And so if people are interested in participating in the outreach program, they will give us their name and phone number, and we'll keep them on a list. So if we get funding for it. Next, please. So this is just a bit of an analysis of that is in the beginning years of our data collection. There was 1,232 calls and a total of 77% at that time, which was 944 of the callers indicated that it was helpful. 3 indicated it was not helpful, and 20% were unknown. Now keep in mind, unknown doesn't necessarily mean the caller might not have answered the question. We might not have been able to ask that question. Or maybe the call terminated before we got to the questions. Next, please. Here's some cost comparisons. The cost savings, this was from 2008 to 2010, and keep in mind we added this question long before we began or started the Warmline, so it's really end of 2009 through 2010 cost savings of $287,000. And these calculations are based on the following information. This information is based on the average cost of services. Warmline cost approximately between $10 and $20 per call. At this time, we knew that it was $10 per call, but we've expanded. So keep that in the back of your mind. Next slide, please. Okay, so this is kind of how we laid it out. 911, when I contacted 911, nobody really knew who to connect me with to find out what the cost of that service was, and then I finally got about an average of $100 per 911 call, depending on the length, etc. So then we were able to show that we were saving $90 every time someone didn't call 911, but they did call the Warmline. Crisis lines, we averaged between $50 and $75 per call, so we were saving $40 for every call. And keeping in mind, crisis lines generally are focused on, getting people to the place that they need. So and they usually only last about 15 minutes. And Warmline calls, they don't really have a length. Hospital emergency rooms, we were told by the state that we really lowballed this number, and we knew that, but we wanted to give an idea. So really that $287,000 is a lowball amount. Would they have accessed the more costly service? And if someone said maybe but didn't know what, we just threw a $25 amount out there. Other is the same. Primary care, $100. Provider, $100, and an unknown of about $50. And we figured the $50 would be about like community programs that, you know, going to your local church or something like that to find resources. Next slide, please. Some things that the Warmline will do will reduce the number of calls to crisis lines. We actually have relationships with crisis lines now, and they literally refer calls to us, so it's helped reduce their crisis line numbers. I mean, calls for those that are maybe ongoing callers that are lonely and just reaching out to touch someone. Provide peer support to peers around the entire state. It reduces psychiatric hospitalizations, increased use of more natural supports. Provide meaningful employment and volunteer opportunities. It provides risk management options for local law enforcement. We collaborate with law enforcement. They have little wallet cards that they can pass out when they go into the community. It demonstrates that Oregon and Warmlines is a pioneer in developing innovative practices, and I'm sure many of you are as well. Next, please. I think I'm near my end of time here. So personal testimonies. I gathered a few of these from an operator. One operator says, "I love this job and I'll work as many days as I can get, not just for money, but I love how I help someone and they help me. I really enjoy doing it. There are days when it's my time to work and not having a good day or week or even a month. And when I get on the line, I'm easily turned around. I wish I could do it every day." And I have called this is from an anonymous caller. I have called the Warmline for over 2 years, and I appreciate having someone to call that doesn't try to fix me. I feel very validated and respected while also realizing that the operator is someone just like me, and we can learn from each other, and I can give back as well as receive. Next, please. This was from an agency staff director. Having a Warmline location here in our county allows us to start a peer-delivered services in our area without a large budget, while also providing a much-needed service to our residents and creating jobs in our community. Next, please. Oh, I'm done. Thank you. Hope that was helpful. For more information, there's my contact information. You're welcome to email me. It's probably the best. And we also have toolkits that we have sent out all over the country and outside the country to help people get theirs started.
Thank you so much, Angel. That was absolutely terrific. And now I'm going to turn it over to Julio Briones, who will talk to us about Warmline technology. Julio, please go ahead.
Okay, great. Thanks, Leah. And Angel, that was really great. I really liked your presentation, so thanks very much. I'm going to speak a bit about how we run Warmline through technology here in Montana. We run it, I'd say, very much the virtual side, like as Oryx mentioned earlier, in that most of our responders are located throughout of our state in Montana. And we sort of did that on purpose in a way because folks from eastern Montana are different than some folks in western Montana, some folks from north are different from south. So we sort of have a mixture of flavor, if you will, in our responders. And like every other Warmline, every person that's answering the phone is a peer that's had some experience with mental health issues, if you will. And so everyone is trained very much I wouldn't say very much the same as what they do in Oregon, but we all have training that we're specified to promote active listening, also promote empathy, and also being just really great peer support for people in Montana. And also we do some crisis response training simply because it's, again, something to do with our liability insurance, as well as people that do call in crisis that maybe don't want to call a normal crisis line or don't want to call 911 or what have you. We do some crisis training as well. But again, we don't advertise as a crisis response line. We do advertise as a peer support warm line, so it's cooler than a hotline, if you will. So next slide, please. And like as I mentioned, everyone is a virtual responder, meaning they usually operate from either their own home or from if they're their own home, or if they are in a group setting at a drop-in center, they can sometimes answer the phone at a drop-in center. But most people that are on our lines operate from either home phones or mobile phones. We do that for a couple of reasons. One is because our callers are spread out. Excuse me, our responders are spread out throughout Montana. And it also gives people the flexibility to answer their phone if they're not at home for some reason, or if they're located stationary, they're able to answer it that way too. And our calls are routed through a phone company called Cutthroat, and they pre-screen our calls for spam, making sure it's an actual caller and not like an auto dialer. And also they screen out what we call abuse callers or ban callers. And I just want to clarify a couple of things about callers that are ever banned. And we don't, those are callers that, let's say, verbally abuse our responders. And as I said earlier, answering these calls is a high stress, sometimes at least high stress type of situation. And all of our callers, our responders are really encouraged to keep their wellness up. And if we have sometimes callers that abuse their responders either verbally, or if they're quote-unquote a sex type of call, we don't allow those calls to repeat very often. They're given the chance to clean up their behavior, and they're invited to call back. If their behavior continues, then we have to put them on a ban list, because we don't have we just don't want to submit our responders to that kind of abuse on the line, because most of our responders are volunteers. We do have some folks that are paid, and however, we have a mixture of paid and volunteer staff. But however, majority of our folks that are on the warm line are volunteers. And so in doing this with virtual responders, again, it promotes a couple of different things. First, it promotes legitimacy for peer support across the state, and it also supports the outlying of our state. I believe it's something like 75 to 80% of towns in Montana have about 2,000 people or less, and a lot of communities do not have a mental health center or easy access to mental health support services. So with that, that's where the virtual responder piece comes out. Between the caller's shift, if you will, the calls are routed to that responder for 2 to 3 hours, depending on what their shift calls for. And then with the help of Cutthroat, at a specific time it routes to another responder. Unfortunately, due to just the amount of people that actually are on the warm line, we only have one responder on at a time. However, we do have the capacity to route it to multiple responders if we have that many people on shift at one time. And it's pretty helpful in that callers get a variety of responders that can support them, and also it prevents burnout from our responders. They're not on excessive amounts of time, and it also gives them time to also practice their own wellness and their own recovery strengths, and increases the resiliency dealing with people that have mental health issues as well. So next slide, please. Right. And again, I think Angel really spoke to this well. We also track our call volume, and we do that for a couple of reasons. One, we're funded by the state at this point, and they really want to know where the calls are coming from. And it's interesting that you mentioned this before, Angel, but I think last quarter was the first quarter that we've seen that our calls are coming, over half of our calls now are coming from out of state, and we've never have and probably will not advertise as a national warm line. However, we're getting majority of our calls now, 55% of our calls now are coming from out of state. So that's not sure exactly why that happened, but it's happening now. So we're getting a heavier call volume, and especially a heavier call volume out of state. And with our tracking software, we're able to basically tell how long the calls are lasting, the time of the day the calls are occurring, and also we don't particularly pay attention to what state they're calling from. All we do is track if they're from Montana or not. So all the or not calls are out of state. All the Montana calls are in Montana, because we try to keep the caller's privacy pretty high, and we don't really record phone numbers or anything like that. The only thing we keep track of is whether it comes from Montana or not. The only time we would ever maybe ever use a phone number is if there's a threat to harm herself, so for the caller, and that's the only time we would ever have to call a person back. At this point, we don't do any callbacks. We just take incoming calls, and that's pretty much that, as far as tracking the call volumes goes. So next slide, please. I want to talk about some things we're doing to connect our responders to the public, if you will. And what we're doing now is podcasts. And what the podcast is starting to feature is our responders talking to the audience about why they do what they do and what benefits it is to them, why people should call the warm line. And we do this for a couple of reasons. As you see on your screen, it gives a voice to our responders as peers. And it also promotes the health of our responders to share their story and share their struggles and share how they've done well and improved in the mental health system. And it allows our callers to maybe connect on a, how to say this appropriately, a non-call type of environment, meaning they're talking to people as, you know, maybe like a teacher as opposed to a counselor, if you will. I probably didn't say that right, but anyway, what I'm trying to say is it puts a human voice behind a responder, and that they're people too that struggle as well, and we're able to share our struggles and promote our mental health to folks that maybe don't know about the warm line, or maybe are questioning whether they should call or not, or maybe they're questioning if maybe being a part of the warm line is something for them. And our podcasts are really a great thing that allow us to connect our responders with the general public. And also what we started to do recently is if our responders go out to trainings or they receive any kind of education, they come online and talk about what they've learned, what benefits it can have for people. For example, mental health first aid is something that some of our responders are starting to do now. And they talk about their experience with training in mental health first aid and really promote that training to the public and to other peers that may be struggling. So it's another way we're using technology to communicate with our audience. And there's a question up there about how long our average call is. We try to keep calls to about 15 to 20 minutes, mainly because of high call volume. However, if it's the person's first call, we let them talk a little bit longer, but we generally try and keep calls about 15 to 20 minutes. Unless it's a crisis call, then that lasts as long as it lasts. So we don't have a time limit on those types of calls. So next slide, please. And this is going to be sort of our newest project that we're working on and gathering funding is, and that is putting a video, if you will, face to the warm line. So the idea is we'll be using Skype or another communication technology like Skype that'll connect our responders using avatars, and that's basically like an image of a face instead of an actual face, to talk to people via Skype. And that's mainly for the caller's privacy. If the caller wants to show their face, they're able to. But again, this is sort of in the beta phase. We haven't gotten all the kinks out yet, but it's something that we're looking to do for a couple of reasons. One is to put maybe a human face to the callers, and again, like we're just testing this idea out, so we haven't gotten a concrete idea if we're going to be using avatars or using their actual face, but as of right now, avatar seems to be the one that would preserve our responders' privacy and also preserve the privacy of the person that's chatting, that's coming in. And we're going to be using those for Warmline and also possibly for support groups as a part of our Warmline package. We're thinking about having general mental health support groups, depression support groups for anxiety, and also bipolar disorder as a part of our Warmline package through Skype. And at present now, the idea is to have it be a weekly type of support group that meets weekly, and just to start out to see what kind of response we get. And if we do get a higher response than we anticipate, then we'll probably move on to more days. But this is another way that we're trying to communicate to an audience that's spread apart a large state, but also connect on a personal level. Even though it's virtual, it's still a personal connection. And so that's something we're hoping to probably bring out at the end of this year, and at least in the phase where we reach out to other drop-in centers about what we're doing. And if it goes well, we're going to maybe reach out to our mental health centers and advertise it on that respect. And we're going to start writing grants to support this project in the next few months. So it should be pretty fun and exciting. I'm pretty excited about trying it out. I'm also very nervous as well. It's not something that I don't know that anyone else is really doing outside of maybe the professional medical field, the professional mental health field. So I'm nervous and excited about trying it out, and hopefully it'll go really well, and time will tell on that piece. And go ahead and do the next slide, please. All right. And I just wanted to give another shout out to the way you can connect with us, and also the ways that we're using communications through technology to connect people with our organization, and also with information from our responders and things of that nature. A couple of quick things about Warmline in Montana that's a bit different is that we run 4 to 10 on the weekdays and 10 a.m. to 10 p.m. on the weekends. We found that through our call volume statistics, those are the hours that we get the most calls. And also, if there's overflow, those sometimes are answered by the help center here in Montana, but that doesn't happen very often. We normally take all the calls of ourselves. And so we operate about 54 hours a week. Most of our paid staff is just on the weekend, and the volunteer staff is during the week. And that's mostly because there's a higher volume of calls during the weekend since we're open longer. And most of the callers that are on the weekend are trained using a program called WRAP, which stands for Wellness Recovery Action Plan. And all of our weekend responders are WRAP trained, and some of them are even WRAP facilitators. And we're looking to connect the weekend responders and all of our responders with mental health first aid, and maybe even assist training for suicide in the coming months. We're really going to see how that goes as far as training goes, and how much it's available, and whether or not there will be a benefit to our callers that call us in. We don't get a lot of crisis calls. I'd say it's maybe less than 1% of our calls are crisis calls. The majority of people call mainly for support, dealing with a mental illness, they're newly diagnosed, they just returned from our state hospital and they want to connect with someone and they're far away from family and friends. That's where the Warmline comes in, and as Angel mentioned, it saves a lot of money for the state, and also connects people with peers in the fact that none of us are professionals. We're all peer support people. We've all been through the mental health system in Montana or somewhere else, and we're not there to fix people. We're there just to listen to them and to provide support in a way that professionals haven't done as of yet. Or maybe we're just another piece of their support system that they use to keep healthy. And we want to connect with people in more ways than the phone at this point. We want to connect with people through podcasts, through Twitter, through Facebook, and also, in the future, again, through Skype. So I'm really excited about the future and what it holds for us. So if anyone wants to connect with us, partner with us, what have you. We'll be interested to hear from you. So if there's any other questions, I can answer that at the end of the presentation. So at that point, that's it for me.
Great. Thank you, Julio. That was just fantastic. So now we're going to open up the virtual floor for Q&A. We'll do our best to get to as many questions as we have in the remaining time. We're scheduled to go up until 2:30 Eastern Time. If we do not get to your question, please be assured that we will be keeping track of the questions that are coming in, and we'll try to respond to your question in a timely manner. So let's see here. The first question that was asked was, people were asking about, someone was asking about the living room model or sort of peer respite alternative to hospitalization, where people can come to speak to peers rather than go to the ER. She was wondering if these organizations operate warm lines in conjunction with the rest.
Unmuted.
I can tell you that, I'm trying to remember, Lenora Kimball in, I'm trying to remember which, New Hampshire has a peer respite center, or started up a peer respite center there, and they also operated Warmline from there. And I can also say that here in Oregon we have different drop-in centers that we have locations set up at as well. So when I talked about, you know, community mental health providers providing funding, we would really find the location, or someone would offer a location for us to operate out of. And some of them are within the mental health organizations, and some of them are outside in peer-delivered service, peer-run organizations. Hope that helps.
I'll just jump in. This is Oryx by saying, yeah, it's very common across the country to have warm lines cohabitating with other programs. So, yeah, it happens a lot.
Great.
And just real quick, I hear in Montana we always, peer respite centers and even also the state mental health hospital, they always provide sort of a little package of call-in numbers for people to contact when they're in respite or when they're just released from either incarceration for a mental health episode or from the state hospital. People always are told to call us if they need some kind of support in that respect.
Mm-hmm.
Great. Thank you. We have another question about, do any of the warm lines conduct outbound support calls if a caller asks for it?
We do in Oregon. We don't do a lot. That's part of the outreach program that we're working towards getting funding for. So for those individuals that call our warm line daily or weekly, we are working towards having a program set up to where they can have a call going to them, and to reduce the amount of time that they call the warm line to free up some of that the call center, if you will. So, and then if someone we don't have that actual program put in place technically yet, so it's not a hugely funded program yet, but it is something that if people say, hey, can you call me next week and check in with me, you know, we will gladly do that. But it's not funded yet, but we'll still do it.
This is Oryx. I used to be the co-director for the Western Massachusetts Recovery Learning Community, and when I was there, we had an outbound warm line. That was the model that we used, so it's definitely a viable model where we had our operators call people on a schedule, and people could sign up to get calls. So that's definitely an option.
Mm-hmm.
Great. We just had a quick question here. Can Angel share how she computes the $10 per call cost?
Oh, I don't have a slide for that. Gosh, it was 4 years ago when we calculated that based off of. That's why it's more around close to $20 per call, between $10 and $20 per call, depending on the length of call and that sort of thing. But in the beginning, we calculated the cost that it takes to pay the phone usage, which is about 7 cents per minute, and then the operator's time, the team leader's time, and all the admin costs at that time were calculated on an average, and that's where the average $10 came. And really, because we've expanded and we've added 2 people to each call now instead of 1, meaning a team leader and an operator, it's closely about $20 per call. On average, but our calls don't usually last more than 20 minutes. We do have calls that last much longer than that, and because of maybe the person's experience at that time is big feelings or what have you, but or maybe they don't realize what we're there for, and how we can be a mutual conversation. So it's an ongoing practice. But at about 20 minutes, we try to, ask the person if they've, if it's been helpful, etc. And can maybe we free up the line for somebody else, and they call back another time. So really, that's about it. It's just calculated the admin costs and all of that. To an average of about $10 per call, 10 to 20.
Super. Thanks, Angel.
Mm-hmm.
The next question is regarding, can you all speak more to the day-to-day supervision necessary for the responders? How do you do that with your Warmline?
I don't want to take up all the time, so I can talk about that, but if somebody else wants to share, I don't mind.
No, go ahead. I'll follow you.
Okay. Well, the way we have it, again, is we have teams. And so as far as supervision goes, because we have them spread out all over the state, I supervise all operators and and team leaders on an administrative level. But the great thing about how we work as teams within each location, because I am far away, we do a lot of ongoing phone calls and conference calls, but the teams itself really do co-supervision, so there's no hierarchical relationship. And if you've been trained in IPS, you learn about co-supervision, how it's about the relationship of the team, it's about the relationship of the group, and how the ongoing intentional peer support practice happens within that group. So what we do is we practice giving and receiving feedback on an ongoing basis, and I can't emphasize enough how much the IPS, Intentional Peer Support by Sharing Mead, has been the foundation of our communication and building our relationships within each team, as well as building the relationships with the callers. And so there's not a whole lot of quote-unquote supervision. They keep each other accountable is what they do, and they help each other through things. And then when I'm needed, or we process on an ongoing basis, if I'm needed, then I help out with scenarios that might be a little more challenging. It works quite well, actually. We haven't had any real major issues, and people are, we have, timesheets and things like that that are signed when people come in, and the technical administrative pieces that of that sort of thing. But as far as the relationship amongst the team, it's pretty amazing how using IPS, how it really flows together and works well.
Did you have anything you wanted to add to that, Julio or Oryx?
I can speak really quick about how the Warmline here. We do weekly callbacks where I call each respondent and we talk about how the week went. And also we do every third Thursday of our month, or every third Thursday or something like that. I forget the day exactly, but we have a group call where all of our respondents call and we do a big conference call, or sometimes we do that via Skype, and we all just kind of meet virtually, see how it's going, and that's how our supervision is done. Usually it's by phone, or if the person's local to us, our home base in Bozeman, we do it face-to-face.
Yeah, that's what we do. We do a monthly conference call where everybody's calling in. And I forgot to mention, sorry, I hope I didn't cut you off. That's the point of having a team leader. Now the team leaders are not there to be supervisors, but they are there to, they're definitely more fluent, if you will, with the IPS practices, so they have more experience in that, and so then they help support the team within that, as well as making sure other technical things are done, like stats and all that other stuff. So that's I can't express enough how important it is to have a team leader in your site, and we now just name them team supports, or lead supports, and not team leaders, because there was this thing that was happening with people where they said, well, I'm the team leader, so that means I'm in this, hierarchical kind of relationship. And we really want to move towards a solid mutual relationship and not any kind of hierarchy within the relationship. So keeping that in mind as well.
Thank you so much, both of you. The next question is for Julio, about specifically wanting to know a little bit more about how Skype or the telephonic support groups tie in or support the Warmline program itself.
Mainly it ties in with the peer support piece, in that all the groups are facilitated by peer support specialists. The telephone and in the future Skype groups will be led by peer support specialists. So it's mainly to sort of expand the personal peer support connection from the one-on-one phone to a group setting, and ideally the connections, let's say the positive connection that you get from a one-to-one call is just expanded to Skype and through telephonic support. And with our telephone bipolar support groups, we get a lot of great feedback from the people that attend, and it's been really, almost surprising how well it's gone for the folks that are talking with other people that have, bipolar disorder, and what their experiences are in the mental health system, what their experiences are out in public, and they're able to talk about things that happen if they're stigmatized or isolated in their local town. At times, they're able to connect with someone virtually on Skype or a telephone support group, and it really, can help reduce stigma, reduce isolation in a sense, and promote, positive self-worth and lessen the feelings of hopelessness that sometimes happen with serious mental health disorders.
I just wanted to add a little bit. This is Oryx. The reason that we're so excited about Skype as a possibility at NEC is because that actually over 70% of communication is nonverbal. So having someone to do peer support where you can see the person is really an exciting possibility, because that nonverbal connection is really important, and it would just add to the support that someone can get. So obviously there's a lot of considerations when doing that, but it's an exciting possibility.
Can I also just mention that you're absolutely right, Oryx, because of the nonverbal. That's one of the challenges of being on the phone, but it's also one of the advantages of being on the phone. So keep that in mind as you're getting trained to see people as well. It's really important to be self-aware of when we're assuming or when we're making assumptions, and that's why we use IPS, because what we see isn't always what's really going on, and it does help, but we can easily interpret our worldview understanding of what we're seeing. It's like 5 people seeing one car accident and having 5 different interpretations of what happened. So that's why we use IPS, so that we're able to ask those types of questions and be aware of our assumptions and our bias, and learning how to ask questions of that we call listening with curiosity, or coming from a position of not knowing. So when you're putting something like that together, I'm excited because we're looking into doing the same thing on the on the Skype as well. But that's one thing that I'm training people to really pay attention to, because you listen differently when you are seeing things sometimes, and you can kind of get stuck in what you're only seeing and hearing versus what's the untold story of what's really going on.
Thank you.
So that's pretty exciting about having the Skype. I'm not saying that that's a bad thing. I'm saying that's the training to be aware of your bias and assumptions is really important.
it brings in a lot more factors, for sure.
Yeah.
So, yeah, and the next question is one that basically is focusing on what would happen in the event of a serious crisis, if somebody is, suicidal or something like that. Is there an immediate link to 911? How do you handle that?
Can I talk on this? Can I just share a quick story?
Definitely.
Okay, we get a lot of calls that are people calling saying that they're feeling suicidal, or that they're going to kill themselves. And I can think of a caller a couple years ago who called that was living in a halfway house, if you will, or supported housing in that way. And the caller actually told the Warmline operator that they had a plan, what their plan was, how they were going to do it, and etc. And of course, the operator is feeling extremely afraid and uncertain, and that's real life, because we're there and we want to help people. But using the IPS as a tool and a foundation, she was able to have a conversation with this person and learn and grow with that person, and ask what just happened or what has happened for that person to get to that place, and getting really deeper into the untold story. And then that mutuality within the relationship, she was actually able to say, I'm wondering, gosh, I'm feeling horrible. I'm sad that you're in such a hurting place. I wonder, would it be okay if I tell you what it was like for me when I tried to commit suicide and it didn't work? And this caller was so baffled that she had ever tried to commit suicide. This person says, oh my gosh, you've tried to commit suicide? And she said, yes, I have, and it was a horrible time in my life. And she didn't go into specific details of what she tried to do and how it played out, but what she did do is she shared a little bit about herself, which then built that connection even deeper and that trust with that person. And that person, and this was an hour-and-a-half conversation, and that person eventually, was saying, well, I don't really want to die, but I'm afraid to tell these people that what I'm experiencing, because they're going to seclude me and they're going to restrain me, and I don't want that to happen again. I'm done. I am out of here. So it was all a lot of fear and based on where the person was at. And if she wouldn't have asked the questions that she did and tried to get deeper and to understand this person's worldview, she might have reacted out of fear and connected that person directly right then and there to a 911 operator or so on. And so that's where, knowing when to get the connection and when not to get the connection, and not jumping out of fear-based reaction. She eventually said, well, I'm wondering if you would like me to help be an advocate for you and help communicate to the people around you. And this person said, oh my gosh, you will do that? She said, absolutely, I will talk to the people if you want me to, only saying what you want me to say, but maybe we can get you the support that you need without it being so traumatizing. That person put the operator on the phone with the staff person there, and that operator was able to be that liaison and be an advocate for that person, and that person called back a week later and said thank you, they needed some med adjustments, etc. But so being able to connect people to 911 or a crisis line is absolutely important to be able to do, but knowing when to do that is really valuable, because you can actually defeat the purpose of the warm line if you're jumping out of fear and not getting deeper to understand the person and why they're feeling the way they're feeling.
That was a really powerful story, Angel. Thank you so much. We have a related question, and Julio, if you want to also jump in on the previous question, you're welcome to. But the question is regarding what do you do when there's a caller who maybe needs more assistance than the responder can give? How have you typically handled that situation?
Well, we usually explore that first, mainly because we want to explore the reason they called us and not call the crisis line first. And usually when you talk with someone and explore what's going on, what they're feeling, what's going on around them in their social support system, if they even have one, what their situation is, usually we're able to bridge that gap and maybe the lack of service they feel like they're getting. If doing all that and it still feels like they're still not getting the support they need, we generally refer them to either a local mental health center in the area if there is one, and or also we connect them with the suicide prevention hotline if they feel like they're not getting the service they need from us. But that does not happen very often. I can maybe count on my hand that's ever happened before, because most of our responders, they've been through a lot of what the callers are going through, if not more. So we don't have a really big problem with that yet. But again, and also it depends if they're calling from our state too. If they're not calling from Montana, it's a little bit harder for us to maybe know what they're going through, because the cultures are different from state to state, obviously. So we do our best to explore what it's like culturally for them as well, and to go from that perspective.
Excellent. Thank you so much, Julio. The next question actually is for you, and Angel, if you want to jump in, you're welcome to. Somebody said that they had heard that Skype is not HIPAA compliant. Is that your understanding? And if so, how has Montana or other states dealt with this?
Yeah, that's true. It's not HIPAA compliant. And from a professional perspective, I believe I stated in the beginning, and I imagine that, again, from a psychologist, psychiatrist, or counselor perspective, I imagine that would change how they bill for it. However, since we don't charge for any of this, and we're run by peers, we don't really deal with insurance when we do a peer support group. For payment, really. But again, that's our board of directors is concerned about that as well. So we're going forward with Skype for the time being. However, if it comes down to the nitty-gritty and they want a HIPAA-compliant type of package, they exist out there. They're very expensive. Is the only drawback.
This is Oryx. My understanding for most peer organizations, because of the billing and the lack of billing and insurance and that type of thing, that HIPAA does not apply to most peer organizations.
Great. Well, we're at about 5 minutes left, so we'll try to get to as many questions as we can in that time. There are actually a couple questions directed towards Oregon about the involvement of insurance companies. What is the benefit of tracking insurance when you're collecting data, et cetera? Just wanting a little more elaboration on that.
Sure. Well, the benefit of tracking is to make sure that that we're out there for everyone, and not just people who are on state insurance, or not just we really didn't know why we would start tracking that, but I felt when I put the stats together that eventually it would maybe become beneficial. And it actually has. We don't ask them for their identifying information, obviously, but now that we're going to insurance companies because to ask for funding, we can show that how many people are actually on Medicaid, Medicare, veteran services, no insurance, and private insurance. And so each group will, each insurance company will look at those numbers and go, oh, okay, well, we might be able to pull money out of this, or we might be able to pay for this because it has X amount of money. And I'm sorry, I visually got distracted.
Sorry.
No worries. I just got disconnected for a second. So, and then the P.E.O. data, which is federal money that goes to the states, and then the states distribute it for prevention, education, and outreach to their regions. That money is tracked by this on the state level. And so if you have Clackamas County and they say they have $250,000 per year to spend on prevention, education, and outreach, and if they don't spend that $250,000 in that 3 years or that 1 year time, they have to pay the money back. So part of the Oregon Health Plan P.E.O. dollars, the incentive is that we can give that county, Clackamas County, the data report for the quarter or for the year, saying, okay, you had 50 callers that called that were on OHP. And so then they have a dollar amount associated with that, and they can have credit for that P.E.O. dollar that would have to be paid back otherwise. So, and then the insurance companies itself, they haven't funded us yet, but we have had some serious discussions, and Care Oregon is one of the insurance companies, and we're looking into potential funding from them because of the data that we have to support whether or not people are on insurance or not. Hope that helped. There's a question here that says, how would I check to see if there's something similar to the P.E.O. in my state? I would check with any administrator of community mental health provider or something like that to find out what their prevention, education, and outreach dollars look like and where it streams through. Because I'm almost 100% sure that every state has prevention, education, and outreach money. I just don't know where it streamed through and how it could tie in.
All right, well, we're getting toward the end of our time, and we're going to try to squeeze in one last question here in the last couple minutes, and it's a big question about getting buy-in from the community to be on board with peer specialist kind of Warmline program for planning and implementation. How do we get the community, I'm imagining they're saying the community and other kind of stakeholders to hear us for our inclusion into the input planning and doing the work it takes to get it done, if that makes sense.
Yeah, I wouldn't try to recreate the wheel. What I personally would do is take and learn from what we're all doing and contact us, and we'll give you statistical data, because a lot of times that's what they need, is to see the financial benefit of it, and then and because they're operating a business, and that was one of the hardest things for David Romprey to really hone in on is, I understand business, and I am all about the people, but I also get that the business people who have money and budgets and difficulties, they need to see the concrete data, and so get our data, take it to them, and present it with them and show them that it's working. And I just want to say that many of the Warmline operators who work the Warmline here, they were people who were callers of the Warmline and then learned that they could do the same thing. And then we got them to, when they were ready, to connect us in their community to help them get jobs in their community. So there was some local buy-in as well. Hope that helps.
Maybe.
I would
Yeah,
echo that
absolutely.
as well. Take data that's already existing and show it that these warm lines, they really do work, and they're really practical and pragmatic and helpful for everyone. So again, I would echo what Angel said, that don't recreate the wheel, use data that's already existing and show how beneficial warm lines are.
Mm-hmm. And to get them to hear you, I think is really sometimes about validating their experiences as well, validating where they're at and their fears. One of the things is we have had counties that would not advertise our warm line because they were afraid of what warm line operators were saying on the other line. So that training piece is extremely valuable and extremely important in having somebody who can articulate to them and address their fears so that they feel comfortable, they as in the community themselves or community mental health providers, whomever it is. There's a lot of fears around, oh, we're going to lose our jobs, or oh, what are warm line operators saying, or oh this, or oh that, and validate that. Yeah, those sound like some great, scary things. Let's talk about what we're really doing and address those fears. Otherwise, you're not going to get them to listen to you.
Yeah, really, really good advice. And unfortunately, we are out of time. We really, really want to thank the speakers and all of you who participated in today's webinar. Again, for those of you whose questions we didn't get to, we are keeping track, and we'll get back to you with responses as soon as we can. Again, please check back soon at Power2You, www.power2you.org on this slide for the archived presentation. And don't hesitate to contact us if you have any questions or need information. Thank you so much again, and have a great day. Thank you.